Yeah, one question that I wish I had asked him afterwards. You always think retrospectively, and hindsight's 2020, right? But
Right.
I was thinking, why didn't I ask, or I should have asked, but why is that trigger point there in the first place? And he very briefly referenced that postures and load placed on the body will cause some kind of, hyperactivity in a ropey band, that type of thing. But and so I wish that I had asked him, well, why don't we just work on reducing that load, which would then be these postural changes that we are often doing. Of course, you and I are similarly biased toward that MDT approach as our toolbox, so to speak, or our clinical reasoning and our approach.
Right.
What are your thoughts on that?
Right. If I recall, Joe did talk about the importance of posture.
You did.
So I guess it gets down to when you're examining your patient, assuming you're doing a complete exam, which going to be your primary focus in that exam, trying to be as efficient as you can within a limited period of time. And we all have our biases. So, we may be biased towards testing repeated end range and changing the person's posture. I would suspect that, the person who's trained in dry needling is going to look at that muscle trigger point and, whether it's active or latent, and look to determine if that may be part of the problem. So we know that, we can't change one tissue or one structure without affecting others. And as we, assume certain postures, that's going to have effects on length tension of muscle and muscle activation and then pain. So the question is, which is the best way to address that? So, if we change the posture and it changes the pain, and the pain affects that input to the muscle, I think we would, as MDT practitioners, agree that may be the ideal way to address it.
Mm-hmm.
And maybe we haven't even tested palpation and looked for a trigger point. And I know I've kind of de-emphasized palpation in my latter part of my career as I learned more MDT and kind of got away from more of a manual therapy approach.
Sure.
But our exam needs to be inclusive, and we don't know if what is relevant that particular day might have an underlying component that may be a factor in the future. So if we're really going to impact healthcare, we need to not only treat the present condition, but look to see how we can prevent future conditions or future incidents from reoccurring. And Rob McKenzie said that years ago. So that can come from, maintenance of correct postures and performance of daily exercise. But if we've never tested if that person has had a trigger point, and we don't know if they ever did, and they have that latent thing going on, could that be a factor in then them coming back? I don't know. So if you've never looked at muscle balance and muscle length, and we talk about this in our McKenzie Fellowship, and that person is back to see us in 6 months to a year, is it because they were not adherent to what we were recommending, or is it because maybe they're not moving around the proper joint axis, result of muscle imbalances or trigger points or a latent trigger point, and now there's change in the force couple and they're back because the load application to lumbar spine is too great and they're back.
Mm-hmm.
So we don't know. But if you don't test it, you don't know. Yeah. And if we're not, thorough in that initial assessment at least, and looking to see what may be the underlying conditions, maybe not the thing that's bringing that person in to see us, but what may be the underlying factors, maybe we can play a greater role in reducing those repeat episodes. And Joe did talk about, an active trigger point being the reproduction of that familiar pain. And we know that reproduction of that familiar pain is relevant and it's important. So whether that is how we address that familiar pain, is it be it through dry needling or correction of posture, is the best way of approaching it.
Yeah.
We don't know. And he talked about, the infraspinatus trigger point, and when you inject it, the person immediately has a change in the range of motion. I believe that can occur. So then the question is it something that we could do to affect that, or have the patient do something to affect that? And I would lean more towards, looking at how the patient may be able to achieve that same result, that short-term benefit. We know that can provide a short-term benefit. So whether it be dry needling or, let's say, repeated shoulder extension improves their flexion immediately, right? So we would classify that as a shoulder derangement. We know that seems to work on the short term. We would say clinically we've seen that. Do we know that keeps it better? I don't know. Do we know if there may have been muscle imbalances or changes in the force couple or weakness in particular muscles or deactivation of other muscles that may cause it to return?
Yeah.
So we know many of the things we do as physical therapists work well in the short term. We don't have a lot of evidence that things work well in the long term. So we need to, continually look at research that supports that. So whether we have end range forces that change the person's response immediately, as we would recommend, could it be dry needling that provides a short term favorable response? Could it be manipulation that we know, an acute subgroup of patients helps provide short-term relief? So whether it's mechanical, neurophysiological, muscle, I think we could argue that. But, how can we impact that person in the long term? So we think in terms of future and impacting recidivism, that if we teach that person well, and they understand and know how to perform that particular exercise or activity or correction of posture, then we may prevent future recurrences. But I don't think we have a lot of research supporting that either.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.